Fast and Easy ECGs, second E, a self-paced learning program. 12. Atrial Dysrhythmias. Fast and Easy ECGs, second E, a self-paced learning program. Atrial dysrhythmias originate in the atrial tissue or in the internodal pathways. Are among the most common types of dysrhythmias, particularly in persons older than 60 years of age. Question to ask: what is the normal pacemaker site which initiates the heartbeat? Instructional point: most atrial dysrhythmias are benign, but tachycardias that originate from the atria can be dangerous. I. Atrial dysrhythmia is believed to be caused by three mechanisms: enhanced automaticity, circus reentry, after depolarization. Instructional point: increased automaticity and triggered activity are disorders of impulse formation. Reentry is a problem with impulse conduction. In increased automaticity, the atrial cells spontaneously depolarize and initiate impulses before the SAR node has a chance to generate a normal impulse. Injured cells sometimes only partially repolarize. Partial repolarization can lead to a repetitive ectopic firing called triggered activity. Reentry occurs when an impulse is delayed along a slow conduction pathway and the impulse is able to remain active long enough to produce another impulse in the atria while the ventricles are repolarizing. Atrial dysrhythmias can diminish the strength of the atrial contraction and affect ventricular filling time. This can lead to decreased cardiac output and ultimately decreased tissue perfusion. Instructional point: the atrial contraction is called the atrial kick and normally supplies the ventricles with about 30% of their blood. Atrial dysrhythmias key characteristics include P waves, if present, that differ in appearance from normal sinus P waves. Abnormal, shortened, or prolonged PR intervals. QRS complexes that appear narrower and normal. Instructional point: with atrial dysrhythmias, the appearance of the P waves will depend on the site where the atrial impulses originate. Typically, the closer the site of origin is to the SAR node, the more it looks like a normal P wave. Also, the QRS complexes may be wider than normal if there is intraventricular conduction defect, aberrancy or pre-excitation. Premature atrial complexes, PACs. Early beats that originate outside the SAR node before it has a chance to depolarize. Premature atrial complexes, PACs, produce an irregularity in the rhythm. PP and RR intervals are shorter than the PP and RR intervals of underlying rhythm. Have P waves that are upright, in lead 2, preceding each QRS complex but have a different morphology, appearance, than the P waves of underlying rhythm. Followed by a non-compensatory pause. Non-compensatory pause is a pause where there are less than 2 full RR intervals between the R wave of the normal beat which precedes the PAC and the R wave of the first normal beat which follows it. Instructional point: the reason a non-compensatory pause occurs is that the electrical activity of the premature atrial beat can enter the sinus node and reset its timing, thus allowing it to fire before its next scheduled beat. This creates an irregularity in the RR pattern. Causes of PACs. Most common cause of PACs is enhanced automaticity. Other causes include instructional point: in some cases there is no apparent cause. Effect of PACs. Isolated PACs seen in patients with healthy hearts are considered insignificant. Asymptomatic patients usually only require observation. Instructional points: PACs commonly cause no symptoms and can go unrecognized for years. The patient may perceive PACs as palpitations or skipped beats. Effect of PACs may predispose patient with heart disease to more serious atrial dysrhythmias. Atrial tachycardia, atrial flutter, atrial fibrillation, can serve as an early indicator of an electrolyte imbalance or congestive heart failure in patients experiencing an acute myocardial infarction. Grouping of PACs. Bigeminal. PACs can be described by how they are intermingled among normal beats. Every other beat is a PAC. Trigeminal. Every third beat is a PAC. Ask question: what do bigeminal, trigeminal and quadrigeminal mean? Quadrigeminal. Every fourth beat is a PAC. Q. Aberrantly conducted PAC. Occurs when a PAC travels through the ventricular conduction pathway abnormally, resulting in an abnormal-looking QRS complex. For this reason they can be confused with PVCs. Instructional point. To tell the difference between PACs and PVCs, look for either a compensatory or non-compensatory pause in the presence or absence of P waves. I. Blocked PAC. Occurs when an atrial impulse arrives too early, before the avenue node has a chance to repolarize. As a result, the P wave fails to conduct to the ventricles. Identified by a premature P wave that is not followed by a QRS complex. Instructional point. Also referred to as non-conducted PACs. Treatment of PACs generally do not require treatment. PACs caused by the use of caffeine, tobacco, or alcohol, or by anxiety, fatigue, or fever can be controlled by eliminating the underlying cause. Frequent PACs may be treated with drugs that increase the atrial refractory time. This includes beta-adrenergic blockers and calcium channel blockers. Wandering atrial pacemaker. Pacemaker site shifts between SAN node, atria and or avenue junction. This produces its most characteristic feature, P waves that change in appearance. Instructional point. With wandering atrial pacemaker, the regularity of the rhythm also varies slightly. I. Causes of wandering atrial pacemaker. Generally caused by inhibitory vagal effect of respiration on SAN node and avenue junction. Other causes include the following. Effects of wandering atrial pacemaker. Wandering atrial pacemaker is rarely serious, having no effect on cardiac output. Normal finding in children, older adults, and well-conditioned athletes. Treatment of wandering atrial pacemaker. No treatment is necessary for patients experiencing wandering atrial pacemaker. However, chronic dysrhythmias are a sign of heart disease and should be monitored. Atrial tachycardia. Rapid dysrhythmia, rate of 150 to 250 bpm, that arises from the atria. Rate is so fast it overrides the SAN node. Instructional point. When the onset of the atrial tachycardia is sudden, and typically witnessed, it is called paroxysmal. I. Causes of atrial tachycardia. Digitalis toxicity is the most common cause of atrial tachycardia. Also, sudden onset atrial tachycardia is common in patients who have Wolff-Parkinson-White syndrome. Other causes include effects of atrial tachycardia. Symptoms can develop abruptly and may go away without treatment. Short bursts are well tolerated in otherwise normally healthy people. Alternatively, they may last a few minutes or as long as 1 to 2 days, sometimes continuing until treatment is delivered. With a rapid heartbeat seen with atrial tachycardia, there is less time for the ventricles to fill. This can reduce stroke volume and lead to decreased cardiac output. Effects of atrial tachycardia can significantly compromise cardiac output in patients with underlying heart disease. Fast heart rates increase oxygen requirements, may increase myocardial ischemia and potentially lead to myocardial infarction. Instructional point. Atrial tachycardia can cause vertigo, dizziness, lightheadedness, syncope, hypotension and congestive heart failure. I. Atrial tachycardia with block. Due to the rapid atrial rates seen with atrial tachycardia, the avenue junction is sometimes unable to carry all the impulses. This is called atrial tachycardia with block. This then results in more than one P wave preceding each QRS complex. Most commonly, only one of every 2 beats, a 2-to-1 block, is conducted to the ventricles. Instructional point: if the block is constant, it will have the same number of P waves preceding each QRS complex, but, if the block is variable, the number of P waves will change. Treatment of atrial tachycardia. Treatment is dependent on the type of tachycardia and symptom severity, directed at eliminating the cause and decreasing ventricular rate. Patients who are symptomatic, for example, chest pain, hypotension, should receive oxygen, and infusion of normal saline administered at a keep open rate, and prompt delivery of synchronized cardioversion, use of vagal maneuvers or medication administration. Treatment of atrial tachycardia. Synchronized cardioversion is indicated if the patient is symptomatic. In the conscious patient, consider sedation before cardioversion. However, do not delay cardioversion. If this fails to convert the rhythm, the energy level may be increased. Instructional point: when atrial tachycardia is due to some underlying abnormality, for example, electrolyte imbalance, drug toxicity, the conversion to a normal rhythm with cardioversion may be temporary because the causative factor has not been eliminated. In such cases, a recurrence of atrial tachycardia soon after successful electrical cardioversion does not warrant additional electrical cardioversion attempts until the underlying problem has been resolved. In the patient with COPD, correction of hypoxia and electrolyte imbalances is indicated. Treatment of atrial tachycardia. If the patient is stable, vagal maneuvers and drug therapy, adenosine, may be used. If these treatments fail to resolve the tachycardia, calcium channel blockers, verapamil, diltiazem, and beta-adrenergic blockers, if no contraindications exist, may be considered. Instructional point: adenosine can be used in aberrancy. If the ectopy turns out to be PVCs, adenosine will not cause any harm. Treatment of atrial tachycardia. Atrial overdrive pacing may be employed to stop this dysrhythmia. If the dysrhythmia is related to WPW syndrome, catheter ablation may be indicated. Procainamide, amiodarone, or sotalol may be considered in wide complex tachycardias. Multifocal atrial tachycardia, MAT. Pathological condition that presents with changing P-wave morphology and heart rates of 120 to 150 bpm. Instructional point: multifocal atrial tachycardia has the same characteristics, changing P-wave morphology, as wandering atrial pacemaker. Appearance of multifocal atrial tachycardia, MAT. MAT is often misdiagnosed as atrial fibrillation with rapid ventricular response but can be identified by looking closely for clearly visible but changing P waves. P waves change in morphology as often as from beat to beat, resulting in 3 or more different looking P waves. Varying PR intervals and narrow QRS complexes also seen. Causes of multifocal atrial tachycardia, MAT, is more common in the elderly. It is usually precipitated by acute exacerbation, with resultant hypoxia, of COPD, elevated atrial pressures, or heart failure. Other causes include effects of multifocal atrial tachycardia, MAT. Patient may complain of palpitations. Signs and symptoms of decreased cardiac output, such as hypotension, syncope, and blurred vision, may be seen. Treatment of multifocal atrial tachycardia, MAT. Appropriate therapy is treatment of the underlying condition. In symptomatic patients, treatment may include administering calcium channel blockers, verapamil, diltiazem. Beta-adrenergic blockers are typically contraindicated because of the presence of severe underlying pulmonary disease. Supraventricular tachycardia, SVT, arises from above the ventricles but cannot be definitively identified as atrial or junctional tachycardia because the P waves cannot be sufficiently seen. Supraventricular tachycardia, SVT. This group of tachycardias includes paroxysmal SVT, PSVT, non-paroxysmal atrial tachycardia, MAT, avenue nodal reentrant tachycardia, atrioventricular reentrant tachycardia, and junctional tachycardia. Supraventricular tachycardia, SVT. Sometimes wide QRS complexes are seen due to an intraventricular conduction defect or other conditions such as aberrant conduction. Makes assessment of SVT difficult as it appears to be ventricular tachycardia, called wide complex tachycardia of unknown origin. Atrial flutter results from circus reentry. Impulse from SAR node circles back through atria, returning to the SAR node region and repeatedly re-stimulating the avenue node over and over at a rate of 250 to 350 bpm. Appearance of atrial flutter. On the ECG, the P waves lose their distinction due to the rapid atrial rate. Waves blend together in a sawtooth or picket fence pattern called flutter waves, or F waves. Produces atrial waveforms that have a characteristic sawtooth appearance called flutter waves, F waves. Causes of atrial flutter. Usually caused by conditions that elevate atrial pressures and enlarge the atria. Another cause is increased automaticity. Other causes include effects of atrial flutter. Often well tolerated. The number of impulses conducted through the avenue node determines the ventricular rate, i.e. 3:1 conduction ratio. Slower ventricular rates, less than 40 bpm, or faster ventricular rates, greater than 150 bpm, can seriously compromise cardiac output. Instructional point. Rapid ventricular rates can produce a loss of atrial kick, decreased ventricular filling time and decreased coronary artery perfusion. This can lead to angina, heart failure, pulmonary edema, hypotension and syncope. I. Treatment of atrial flutter. Vagal maneuvers may make flutter waves more visible by transiently increasing the degree of the block. In patients experiencing an associated rapid ventricular rate who are symptomatic but stable, treatment is directed at controlling the rate or converting the rhythm to sinus rhythm. Treatment of atrial flutter. Symptomatic patients, for example, hypotension, signs of shock, or heart failure, should receive oxygen, and infusion of normal saline administered at a keep open, TKO, rate, and prompt treatment. Synchronized cardioversion should be considered in unstable patients. If necessary, the energy may be increased with subsequent shocks. Atrial fibrillation. Results for chaotic, asynchronous firing of multiple areas within the atria. Instructional point. It is believed that atrial fibrillation stems from the rapid firing of ectopic impulses, greater than 350 beats per minute, in circus reentry pathways. I. Appearance of atrial fibrillation. Totally irregular rhythm with no discernible P waves. Instead there is a chaotic baseline of fibrillatory waves, F waves, representing atrial activity. Causes of atrial fibrillation. Atrial fibrillation is more common than atrial tachycardia or atrial flutter. It can occur in healthy persons after excessive caffeine, alcohol, or tobacco ingestion or because of fatigue and acute stress. Other causes include effects of atrial fibrillation. Leads to loss of atrial kick, decreasing cardiac output by up to 25%. Patients may develop intra-atrial emboli as the atria are not contracting and blood stagnates in the atrial chambers, forming a thrombus, clot. Predisposes patient to systemic emboli, stroke. Treatment of atrial fibrillation. If the rate of ventricular response is normal, the dysrhythmia is usually well tolerated and requires no immediate intervention. Patients experiencing atrial fibrillation and an associated rapid ventricular rate who are symptomatic but stable, treatment is directed at controlling the rate or converting the rhythm to sinus rhythm. Treatment of atrial fibrillation. Symptomatic patients, for example, hypotension, signs of shock, or heart failure, should receive oxygen, and 4 infusion of normal saline administered at a TKO rate, and prompt synchronized cardioversion. If necessary, the energy level may be increased with subsequent shocks. Practice makes perfect. Determine the type of dysrhythmia. Answer: atrial rate 375 bpm, ventricular rate 100 bpm, regular rhythm. Atrial waveforms have sawtooth pattern. F waves are present. QRS, more accurately described as RS, complex is at 0.08 seconds. PRI immeasurable. QT immeasurable. Atrial flutter with a 4:1 conduction ratio. I. Practice makes perfect. Determine the type of dysrhythmia. Answer: atrial rate is greater than 350 bpm, ventricular rate 100 bpm, totally irregular, P waves are indiscernible. F waves are present. QRS, more accurately described as QS, complex is at 0.12 seconds. PRI is immeasurable. QT is immeasurable. Atrial fibrillation. I. Practice makes perfect. Determine the type of dysrhythmia. Answer: atrial rate 65 bpm, ventricular rate 65 bpm, occasionally irregular, due to the premature beat, normal and upright P waves in the underlying rhythm. P wave of premature beat differs from P waves of underlying rhythm. Notched QRS complex is at 0.10 seconds. PRI 0.16 seconds. QT 0.38 seconds. Normal sinus rhythm with a premature atrial complex, PAC. Second beat. I. Practice makes perfect. Determine the type of dysrhythmia. Answer: atrial rate 300 bpm, ventricular rate 70 bpm, variably irregular rhythm. Atrial waveforms have sawtooth pattern. F waves are present. Normal QRS complex is at 0.08 seconds. PRI immeasurable. QT immeasurable. Atrial flutter with a variable conduction ratio. I. Practice makes perfect. Determine the type of dysrhythmia. Answer: atrial rate 80 bpm, ventricular rate 80 bpm, regular rhythm, varying P waves. Normal QRS complex is at 0.08 seconds. PRI varies. QT 0.32 seconds. Normal. Wondering atrial pacemaker. I. Practice makes perfect. Determine the type of dysrhythmia. Answer: atrial rate 60 bpm, ventricular rate 60 bpm, occasionally irregular, due to the premature beat, normal and upright P waves in the underlying rhythm. P wave of premature beat differs from P waves of underlying rhythm. Normal QRS complex is at 0.10 seconds. PRI 0.16 seconds. QT 0.48 seconds. Normal sinus rhythm with a premature atrial complex, PAC, second beat. I. Practice makes perfect. Determine the type of dysrhythmia. Answer: atrial rate 214 bpm, ventricular rate 214 bpm, regular rhythm, P is absent. Normal QRS complex is at 0.08 seconds. PRI is immeasurable. QT 0.28 seconds. Supraventricular tachycardia. I. Practice makes perfect. Determine the type of dysrhythmia. Answer: atrial rate 58 bpm, ventricular rate 58 bpm, frequently irregular, for what you see on the tracing, normal and upright P waves. P waves of premature beat differ from the P waves of the underlying rhythm, and one is buried in T wave of the preceding beat, QRS, more accurately described as RS, complexes at 0.10 seconds, PRI 0.24 seconds, QT 0.48 seconds. Sinus bradycardia with two premature atrial complexes, PACs, 4th and 6th beats. There is also a first-degree avenue heart block. I. Practice makes perfect. Determine the type of dysrhythmia. Answer: atrial rate 120 bpm, ventricular rate 120 bpm, irregular, varying P waves, normal QRS complexes at 0.06 seconds, PRI measurable, QT 0.28 seconds. Multifocal atrial tachycardia. I. Practice makes perfect. Determine the type of dysrhythmia. Answer: atrial rate 60 bpm at first, then immeasurable, ventricular rate 60 bpm accelerating to 167 bpm, regular then sudden acceleration in heart rate, normal P waves then absent, normal QRS complexes at 0.10 seconds, PRI 0.20 seconds, QT 0.44 seconds. Paroxysmal supraventricular tachycardia. I. Summary. Atrial dysrhythmias originate outside the SAR node in the atrial tissue or in the internodal pathways. Three mechanisms responsible for atrial dysrhythmias are increased automaticity, triggered activity, and re-entry. Key characteristics for atrial dysrhythmias. P waves, if present, that differ from sinus P waves. Abnormal, shortened, or prolonged PR intervals. QRS complexes that appear narrower and normal, unless there is an intraventricular conduction defect, aberrancy or pre-excitation. Summary. With wandering atrial pacemaker, the pacemaker site shifts between the SAR node, atria and or avenue junction. Produces its most characteristic feature, P waves that change in appearance. Premature atrial complexes, PACs, are early ectopic beats that originate outside the SAR node. Produce an irregularity in the rhythm. P waves should be an upright, in lead 2, preceding the QRS complex but has a different morphology than the P waves in the underlying rhythm. Summary. Atrial tachycardia is a rapid dysrhythmia, rate of 150 to 250 beats per minute, that arises from the atria. Multifocal atrial tachycardia, MAT, is a pathological condition that presents with the same characteristics as wandering atrial pacemaker but has heart rates of 120 to 150 beats per minute. Supraventricular tachycardia arises from above the ventricles but cannot be definitively identified as atrial or junctional because the P waves cannot be seen with any real degree of certainty.